Thanks, Mary. And thanks, Empower Idaho, for everything that you're doing. These webinars are a pretty great resource for our community. So I just really appreciate all of you guys' work on this. I'm happy to talk about parity updates. I'm really happy to talk about parity just about any time. It's a subject near and dear to my heart as a therapist and an advocate for mental health. So I'm happy to help people understand. If you have questions, put it in the chat. Mary is going to kind of monitor that and ping me as those come up, and hopefully we'll get those questions answered for everybody. Okay, so as for the agenda for today, we're going to talk about what parity is. It's one of the longest acronyms I've ever heard. MHPAEA, Mental Health Parity and Addiction Equity Act. Some of the background, where it came from, how long it's been around. Then we'll go into what are called NQTLs, non-qualitative treatment limits. We're going into that pretty heavily because most of the parity rules, and specific to the final rule that has just recently come out, is around NQTLs. So it's important for us to all know exactly what those are, go into those updates. And then at the end, my hope is to give you some resources that you can help advocate for and with and educate yourself even more. So what is mental health parity? In a nutshell, the easiest definition of it is equal status and equal pay. As it applies to healthcare, really what it means is that insurers or panels are not allowed to impose greater restrictions on mental health or substance use disorder services as they already do for medical surgical services or MS services. They have to be treated equally, and patients need to be given equal access to services in both of those categories. This has been around for actually quite a while, over a decade. The original Mental Health Parity Addiction Equity Act, MHPAEA, was enacted in 2008. It applied mostly to large health plans, and it had a lot of exceptions early on. Then came the Affordable Care Act in 2010 that extended parity to include mental health and substance abuse in the essential benefits. The reason that was important is, one, once it was included in the essential benefits packages, then parity extended to a broader group of panels, extended to small group plans and individual plans as well. 2013, there were some final regulations that came out that included the current NQTL rule, which we'll get into and I'll explain a little bit more. Then in 2018, something called the Millman Report came out, and ultimately it was a data study that was given to Congress to see, hey, since 2008, since the beginning of this MPHEA, right, since it started, have we seen any kind of progress? And what the Millman Report reported was there was very little, if any, progress. So patients were still paying between 40 and 100% more for behavioral health than medical surgical. There was a lack of access, a lack of providers. Providers were paid about 22% less than medical surgical. In addition to that, there was a self-compliance. It was the first time there was a self-compliance tool issued to give panels and give plans some sort of a tool to help them walk through parity and get compliant. In 2020, that tool was updated to give plans a little bit more direction because it is difficult. In 2021, the Consolidated Appropriations Act passed. Ultimately, what that did is strengthen state and federal powers to ensure compliance for panels. In 2023, the report to Congress proposed additional legislation because they were finding that really the mental health parity wasn't being enacted, and we needed a little bit more teeth to make sure that it was getting enacted. Then in 2024, just recently, actually, a month ago, September, I believe, so 2 months ago, it's November now, final regulation and compliance guidance was mandated by the 2021 ACA, and we have the final rule. So that kind of gives you, albeit a very, very general overview of how we got here. It still applies to only some plans, not all. So it applies to plans sponsored by private and public sectors with employers more than 50 or employees more than 50, both self-insured and fully insured. Health insurance companies that sell coverage to employers with more than 50 employees, grandfathered and non-grandfathered, unless they are exempt. That's actually changed this year. There used to be grandfathered plans, and there really aren't. The parity exemptions are retiree-only group plans who opt out, individual and group plans offering only accepted benefits, self-insured or non-federal governmental employer plans who receive the exemption or opt out because of these two. Cost increase is greater than 2% for the first year, and 1% any year after can apply for an opt-out to be exempt from parity. And small employers, 2 to 49 employees, still must provide essential health benefits under the ACA. So even though they would, if we go back here, even though the exemptions do apply to employers where it's 50 or below or under 50 employees, because essential health benefits also applies to those folks, under the final rule, they are still required to meet parity standards. And the others who can opt out are a HIPAA opt-out. And there's a link there for you if you'd like to take a look at it. It's state by state. And it includes all of the insurers who have gotten a HIPAA opt-out. Interestingly, on that list, Idaho is not on them. So we currently don't have a plan in Idaho that has a legal exemption for parity. That's not to say parity applies to all of them. There's some still under these, right, that it doesn't apply to. But those that it does apply to and have gotten an exemption, there are none in Idaho. Medicare is exempt from parity, and so is insurance under the Veterans Administration, the VA. Okay. So we'll talk about parity and the three different types of benefit restrictions that are involved. One is financial. Now, these are restrictions that a panel, an insurance company, might put on folks that look like separate co-insurances or separate co-pays, right? So if I have a separate copay for medical surgical and a separate copay for substance use disorder, that would be an example of a financial benefit restriction. Limits to out-of-network benefit limits that might be different for substance use or mental health versus medical surgical. Deductibles that might be higher or separate for medical surgical versus mental health. Then there's qualitative treatment limits. These are things that you can count, limits to the scope or the duration of benefits. So in other words, you can only have 6 sessions a year for mental health counseling for schizophrenia. Or you can only have 45 minutes, what is it, 90834. We can only use 90834 instead of the hour-long benefit for, let's say, treatment of schizophrenia. Those would be examples of qualitative health limits that plans often have in place. And again, we're not talking about those being illegal or against parity. It's a parity violation if those treatment limits are not equal to what they do in medical surgical. So if we're seeing it in mental health, then we need to look at the benefit plan on medical surgical and see if there's a comparable service that has those same limits. Then there's non-qualitative treatment limits. That's the focus mostly of what we're talking about today, because that's been the focus of some of those final rules in the legislation that has been updated this year. Those limits are harder to track and harder to count. Those are things like limits based on medical necessity or appropriateness, or what we call investigative or experimental network or tier designed. So, preferred or participating providers. Those are examples of non-qualitative, and we'll dive more into what each of these final rules look like and what plans can and cannot do now as they develop those NQTLs. So here's some examples, some more very specific, right? Standards limiting or excluding benefits based on medical necessity or appropriateness, or whether a treatment is considered experiential or investigative, okay? formulary design for prescription drugs, network tier designs, preferred or participating providers, standards for providers' admission to a network. So in other words, like 2 years, 2 years post-license, if a plan has that requirement in place, that it also needs to be in place for comparable medical surgical services. Plan method for determining usual or customary charges, which is a fancy way for saying reimbursement rates. Refusal to pay higher cost therapies unless lower cost therapies are not effective. There's another example. Some of them call it step therapy protocols. Exclusions based on failure to complete a course of treatment. And then restrictions on scope or duration of benefits that are based on either geographic location, facility type, provider specialty, or other criteria. So some of these can be difficult to sort of understand. For me, I find it super helpful to have specific examples, and we're able to pull some from recent legislation that has been happening over the past 2 or 3 years. Here's one at the top with Health Net Life Insurance Company. And the plan was found to have violated parity because the scales that they were using to determine medical necessity for clients' inpatient eating disorder treatment was more stringent than the scales for medical surgical services, because it required, the mental health one, required the client to exhibit acute symptoms to qualify for subacute levels of care when they compared them to the skilled nursing facility, inpatient hospice, and rehabilitative services. Those were the examples of what the court deemed as comparable services, and none of those excluded based on medical necessity. So that's a good example of what they considered a parity violation. There was another one with Anthem Blue Cross Blue Shield. The plan's written policy and the application of their discharge criteria, so how they treated it for inpatient mental health treatment, was more restrictive than those used for medical surgical. Skilled nursing is what they used again, in that it allows for discharge from the mental health treatment, right? It allowed for discharge immediately on admission, rather than only in the last 3 states of treatment following the development of a treatment plan. So what that means is that in skilled nursing services, only allowed for discharge only in the last 3 stages of treatment following the development of a treatment plan. But for mental health, they were allowed to discharge immediately upon admission. And so that made it more restrictive and a parity violation. Here's one that was found to not be a parity violation with what is it, Group Health Co-op of South Central Wisconsin. And these are very specifically legal cases that are cited. So if you want to Google them, this is how you Google them. The plan disallowed coverage for speech therapy for autism spectrum disorder, though it did allow for chiropractic. Found no violation as there was no disparity between the processes or sources used to create the criteria. Does that make sense? So the only reason it would be a violation, they can still deny services, but the only reason that it would be a violation is if they don't use the same criteria to deny for, let's say, chiropractic as they do for speech therapy. And here's another violation with the U.S. Department of Labor, Health and Human Services, and U.S. Treasury. The plan included exclusions for coverage for mental health or substance use telehealth services, with no similar exclusion for medical surgical benefits. So medical surgical could use telehealth and mental health, and SUDS could not. The plan proved more restrictive in access policy and application, as it required members to call for an approval prior to accessing the EAP for mental health and SUDS, and that restriction was not present for medical surgical comparable services. Does that make sense? So sometimes looking at these cases, I think, help us figure out how they're looking at these NQTLs and what specific examples. So the new rule really, it doesn't change the rule. It just strengthens and changes compliance requirements for the plan. So those NQTLs, those NQTL requirements have been in place, remember, since 2010. So we didn't need to strengthen those. We needed to strengthen the compliance of it. So that's what the new rule in September really did. Okay. And here's what it did. It did, I think, it 4 or 5, can't remember how many, 5 very specific categories. One is the meaningful benefit requirement. And what that means is the plan must provide meaningful benefits in 6 classifications in which meaningful medical surgical benefits are required. So basically, in these 6 areas, if the service is provided for under medical service or medical surgical, then it also needs to be provided for in mental health and SUDS. Emergency services, in-network inpatient, out-of-network inpatient, in-network outpatient, out-of-network outpatient, and prescription drug. Does that make sense? So if we have, if a, excuse me, if a plan covers services, let's say in out-of-network inpatient for medical surgical, then they need to have comparable services covered for mental health and SUDS in that classification of out-of-network inpatient. So what this might look like, what the impact is, an example, a plan that provides coverage for medical surgical core treatments for opioid use disorder, so like buprenorphine, things like that, in an outpatient in-network prescription and prescription drug classification. It must also provide coverage, mental health SUDS outpatient in-network, so in other words, counseling and behavioral therapies and prescription drug classifications. So that's the impact, that there has to be a meaningful benefit in both. The second rule is the prohibition of discriminatory factors and evidentiary standards. So really, with the plan may not use discriminatory information, evidence, or sources or standards that systematically disfavors mental health or SUDS. This is a tricky one because it really goes in and looks and very carefully audits plans and how the sources that they use to determine mental health and SUDS policies and practices. So if the plans are using either outdated or they're cherry picking their sources to support their NQTL policy or its delivery, they won't be able to continue to do that. Okay, so that's number 2. Number 3 is they've modified some key terms, which on the surface sounds a little less important, but is really vital actually to moving this forward. So what the final rule says is medical surgical benefits, mental health benefits, and SUD benefits no longer incorporate state guidelines, but instead point plans to follow the most current version of either the ICD's, International Statistical Classification of Disease, that's ICD-10, and related health problems, or the DSM, the Diagnostic Statistical Manual of Mental Disorders. So no longer can plans cite state guidelines. They have to use the medical coding terminology. And it redefined key terms used in performing the analysis, and we'll talk about the comparative analysis here pretty soon. It redefined what evidentiary standards are. So again, that goes back to this slide, that the evidentiary standards and where they have to come from, and very specifically what they can and cannot use. Factors that include processes and the strategies. So not only the policy and how you write it down, how the plan writes it down, what they're going to do, but also how that policy is being enacted on a day-to-day basis. So the factors that go into that, and then the processes themselves and the strategies. So it redefined those factors. The impact is that plans must use current medical diagnostic criteria, not state law, to determine definitions for mental health and medical surgical diagnosis. So an example, if state law defines serious mental illness as unable to care for oneself, but the DSM, sorry, that's inverted, DSM or ICD-10 defines it as serious implications in life domains, including minimum of 3 out of the 5, then we have to use the latter. So here's a good example. Hopefully you all can see this. Oh, Will it come up? Yep, it will. Hopefully you can all see this. Mary, can you confirm everybody can see this?
Yes.
Okay, great. So this is Idaho statute title 67 for the Department of Administration as it relates to mental health parity in state group insurance. So this is state group insurance for state administered funds, right? They define serious mental illness as these 6 things: schizophrenia, paranoia, other psychotic disorder, bipolar disorder, major depressive, schizophrenic disorder, schizoaffective, excuse me, panic, and obsessive compulsive disorder. So that is state law. And what the new parity rule states is that plans can no longer reference state law to determine these policies and determine their processes and their strategies. They have to use either the ICD-10 or the DSM. So those are pretty important modifications to key terms that will help keep plans from being able to kind of cherry pick which one supports an NQTL. Fifth, I think we're on the fourth. Monitoring for material difference in access. So a plan must collect and evaluate data to assess the impact of NQTLs on access to mental health and SUD services and take reasonable action when they know or should know an NQTL may be causing material difference in access to mental health and SUDs as compared to medical surgical. So the relevant data that plans are now being required to mine consistently all the time might be numbers and the percentage of claims denials. So if they look at the number of claims or a percentage of claims denial or SUDs versus medical surgical, and they see a significant difference, let's say mental health and SUDs is getting 20% higher, it might be an indication that access, that there's a material difference between the two and they need to reevaluate those policies. Network composition, network composition is who they're all, how do I articulate that? Who your providers are, where are they all located? If they look at medical surgical and they have a certain number of providers per area, and then you look over at mental health and SUDs, and they have a material difference, a significant difference between the number of providers that folks can access for mental health versus medical surgical, then the plans are required to take a look at that and change those policies. Utilization rates, this is really similar to the percentage or claims denials, except utilization rates in network and out of network are the rates that services are actually being used. So if I'm looking at, let's say in network, medical surgical, and 90% or something of my patients are utilizing and accessing in-network services, and my behavioral health or my mental health and SUDs is using 90% out-of-network benefits, then most likely there's a material difference there, and the plan needs to take a look and make some changes. Network adequacy measures similar to utilization rates like we just discussed, right? And provider reimbursement rates. So pretty historically over time in the Millman report, I think the last one, although APA did one recently that showed mental health and SUDS providers being paid about 26% lower than comparable services in medical surgical. So this would constitute a material difference in access, because this is where you get providers no longer wanting to be in network and things like that because of those reimbursement rates significantly lower. So plans, when they find those differences, they're required to take action. If a material difference exists, this is some examples of what the plan may need to do. So let's say the example that the material difference that a plan uncovered was that they had low network composition. So they didn't have very much access, like across the entire state, or diversity of access, those kinds of things. So then some actions that the panel might take in order to rectify this might be that they strengthen efforts to recruit providers. They expand telehealth availability, provide assistance to members to find providers, ensure providers, directories, that's supposed to say directories, ensure provider directories are accurate. So those of you out there listening that are providers, now you're knowing why you're getting all of those emails that says, well, it's like once a month now that says, make sure your information with us is accurate. Part of the reason that they're doing that is that there is a lot more consequence to those panels if they're not keeping those provider directories accurate. Then we get to the comparative analysis requirement. This is one of the last requirements, and it requires panels to submit to the Department of Labor an analysis of all their NQTLs. Plans must conduct regular analyses of the design and the application, so not just one or the other, not just the policy or how they enact the policy, but both of NQTLs that include details in the following 6 elements. A description of the NQTL with a listing of the benefits that are subject to it, identification factors and evidentiary standards used to design or apply the NQTL. So if here's the treatment limit that we have, and here are the resources, whether they be, medical journals, etc., that we used. Here's a published resource list of the factors that we used in order to develop that NQTL. A design of how the factors are used, demonstration of comparability and stringency as written, demonstration of comparability and stringency in operation, including required data, evaluation of data, explanation of like when there is a material difference, the explanation of that difference, and a description of the reasonable actions taken to address the differences and findings and conclusions. So the way I think about this in some of my consulting work is when I go in and do an audit, we sort of take a look at the whole thing, and then we develop an action plan. Like, here's the problems that we identify, similar to a treatment plan. Here's the problems that we've identified, and here's the treatment plan. And that's really what this comparative analysis is all about, is here are the problems, but also this list of things that we don't consider problems. Here's all of the data that went into developing those so that an outside auditor or the oversight committee can take a look at it and decide whether they agree or not. Plans are required now to make copies available to plan participants or relevant state and federal authorities upon request. And I think that's a really, really important one, is to know that all members have the power to ask and request for copies of the comparative analysis and to be able to take a look at it. And the impact of that, the processes, strategies, evidentiary standards, other factors used to design NQTLs in a class are comparable to and applied no more stringently than those used in designing and applying NQTLs for medical surgical benefits for the same class, right? Now, by impact, I mean, this is the goal, right? The impact on panels, obviously, is that there's a pretty significant amount of work now that is going to go into each of these NQTLs, determining where they came from, what's the evidence that supports them, what are the factors that went into it, then how are the NQTLs being applied, not just how it's written, but how it's applied. So that's a significant amount of work on behalf of panels that they need to undertake. What enforcement now looks like, and this is a big part of what happened in September. Big part of the final rule was really, like I said, about enforcement, right? So it includes, they say fast-paced, and it really is fast-paced because it needs to be done pretty quickly. Comparative analysis request and review process must utilize to ensure compliance. Plans must be prepared to provide copies of it to both the Department of Labor and plan participants when plan participants ask or request it. Department of Labor may request a copy, and plans must furnish it within 10 days. So it is super fast paced, right? Yep.
Kim,
Yep.
there's a question. Who does the audit? The Department of Insurance?
That is a great question. So the, um, it's a great question, and it's a hard one to answer because it really depends on the insurance company. Insurance companies, with the exception, I think, of ERISA covered insurance plans. You'll hear, the more you do some research on this, you'll hear ERISA thrown around a lot. In a nutshell, it is another law that covers insurance plans. Admittedly, I don't go heavily into ERISA because it is separate and distinct from Parity. So we mention it a little bit, but I don't go heavily into it. But for those ERISA plans, the new final rule does state that they have to have an outside entity do the comparative analysis. Okay. So it's a little bit different than an audit. It's a comparative analysis. It's happening for most plans, it's happening internally. Then it's given to the Department of Labor. Odd, I know, but for most plans, not all, but for most plans, their governing authority is the Department of Labor. I should say for most plans that Parity covers. Their governing authority is the Department of Labor. So each internal audit system, each panel does this comparative analysis, gets it over to the Department of Labor, and any plan participant, so it's supposed to be public knowledge, any plan participant that requests it, then the department or anytime the department, let's say the Department of Labor gets a complaint, they go to the panel and they say, hey, give us your comparative analysis. And the panel is required to provide it within 10 days. Does that make a little bit better sense? I'll keep moving forward. And Mary, just interrupt me if people still have questions. If a plan is out of compliance, okay, if the Department of Labor looks at that comparative analysis and says, nope, you need to fix these things, get an action plan in place. If they're still out of compliance, they have an additional 45 days for the plan to issue corrections to the problem areas, and then issue another analysis over to the Department of Labor. So again, pretty fast turnaround on these things. If they're still out of compliance, then the Department of Labor has a little bit more that they can possibly do. Some examples of that might be that they would direct the plan to completely cease the use of the NQTL. They might tell them to change it and specifically how to change it, or they might issue fines. There's a number of different things that they can do, but the plan must distribute the notice. So if the plan remains out of after the 45 days in the corrective action plan, and the Department of Labor gives a final determination of noncompliance, then the plan has 7 days to notify all their beneficiaries and participants of their lack of compliance. Reason that's really important, like I'm a small employer. I have far less than 50 employees. I think I have 3. So reason that is important is because of ACA and those essential benefits, I'm required to still meet parity. So I rely on my insurance broker who knows that I can only choose from plans that follow parity. So if they get an issue of non-compliance, then I, as a small employer, most likely have to look at other health plans. I can't purchase this one because it doesn't qualify for parity. So hopefully that makes sense. So it's some downstream consequences, but pretty significant consequences. Plan, again, I want to emphasize it. Plan participants and beneficiaries can request copy of the plan's analysis after receiving an adverse benefit determination anytime or anytime under the ERISA plans. When we get to the end and we get to some resources, I'm going to help give you guys some resources to start figuring out which of these plans does parity apply to, because sometimes that can be the most difficult first step, is just figuring out, does parity apply to this plan? And then if it does, was there a parity violation? And that can be a little tough at times. Any applicable state authority may request a copy of the analysis. So who that might be, some of the Health and Human Services, district, state health authority, insurance commission, people like that. Dates of the final rule. Final rule goes into effect on the 1st of January 2025, with the exception of the prohibition of discriminatory factors. It's delayed for a year just to allow more plans more time to comply, because really what that one requires plans to do is a whole do-over. It's going back into each of those treatment limits and doing more research and finding current medical research that is not cherry-picked, that supports the development of a treatment limit, instead of using outdated or past resources that aren't allowed resources. Okay. How are we doing on questions, Mary? Are we doing okay?
We're doing fine.
Great. So I have just a 4-minute video I think is important for people to see by paritytrack.org and Senator Kennedy, who was the one who wrote the law. Hopefully this will run.
1 out of 4 Americans is directly affected by a
Ooh. Let me close a couple of
mental
these.
health condition or addiction. That means you or someone you love has a diagnosable and treatable condition like anxiety, depression, or an eating disorder. Maybe you know someone seeking help for an addiction to alcohol or opiates. Mental health affects all of us. And like many, you probably rely on private insurance for your health care, including your mental health care. Getting the treatment for your condition can be difficult. It's not because you don't want to find a doctor and be treated. It's because when you do, insurance companies often deny your claims and leave you wondering why. It can be a mysterious and frustrating process for some, and even life-threatening for others. Has this happened to you or someone you know? You're not alone. It's happened to countless people from all over the country for many, many years, and it's time to put it to an end. You have rights under something called the Parity Law, and I'm here to tell you what you can do right now to protect yourself and get the care you need. But first, what is parity? It's important to understand because parity is your right. Let's take a step back for a second. Let's imagine that you had diabetes or heart disease. Your doctor would know exactly how to treat you, and your insurance company would know how to cover those services. They're in the business of healthcare after all, and to them, treating your illness now will save them money down the road. It's called prevention. What we do for physical health, we rarely do for brain health. It's hard to understand why. And as a result, insurance companies routinely deny coverage for mental health conditions and addictions, treating the brain as if it's not really part of the body. And for a long time, they've gotten away with it. But under the Parity Law, they shouldn't. In fact, if they don't offer mental health and addiction services at the same level as other medical benefits, insurance companies are breaking the law. Parity is just a fancy way of saying fairness and equality. Your mental health care should be on par with your physical health care. No higher copays, no higher out-of-pocket costs, no unfair treatment limitations, period. What's good enough for the body should be good enough for the brain. And those denials of care I mentioned, well, they're probably a violation of parity, a law that's almost a decade old. So why am I telling you this? I wrote the law when I was in Congress because I saw what I still see now: big problems, shattered lives, and a fundamentally unfair system. In fact, I believe that access to mental health and addiction care is a civil right and something we need to protect and defend. If parity is indeed a right, then what does it mean for you? If you receive one of those denial letters, I'll bet you've asked yourself what you could do. For a long time, the answer was not much, unless you were willing to enter a bureaucratic maze that few actually came out of. Or you might try to hire a lawyer, but many of us don't have the time or money for that. But now there's a way to appeal a health plan decision. Those denials are not the last word. That's why I want to take a minute to walk you through this appeals process. in the hopes that you'll use this information to get the care you are entitled to. Step 1, visit parityregistry.org, and there you'll find information on how to file an appeal and join our new complaints registry so we can work together to put an end to those denials. We need to show the insurance companies that we mean business. We can only do this if we have you and your friends and family members on board. Second, log your complaint in our system. We'll use it to show how many people are in the same position as you. We need to hear your voice and your story. That's how change happens. Third, use the website's resources to educate yourself on the appeals process. We won't be able to file the appeal for you, but in 10 minutes, you'll be able to learn how to do it for yourself. That power is in your hands. Fourth, exercise your rights. Share this tool with others and make your voice heard. Access to mental health and addiction care is your right, and protecting that right is part of our common struggle. We are all in this together, and I hope you will join me in taking on the unfair and illegal practices of the insurance industry. If you have questions, be sure to visit parityregistry.org and send us an email. Thank you.
Nice. And obviously, when he's talking about Parity being almost a decade old, that dates the video quite a bit. I think it's a good video because it's really palatable to a lot of folks to be able to understand what rights are. The rights have not really changed. What has changed since that video is the enforcement, and I'm happy to remark, the compliance. A lot more attempts have been made to try to comply with parity, and I'm hopeful with the new legislation and the final rule that it'll pull the rest of those panels into compliance. So a question I get a lot is, what are some resources? Like I said, the first step, really, when somebody is considering whether there's been a parity violation, is to find out if the health plan is subject to parity. And sometimes that can be a little bit difficult, but the first step is contacting your employer's plan administrator. They should know. The Department of Labor can help with that. There's a phone number. You can click on that link or go to Ask EBSA, departmentoflabor.gov. And you can submit into specific insurance panels, and there's some answers there. Like the video talked about, there's some really good information on Kennedy Forum. The first step in all of this, like I said, is to find out if the plan covers parity. One of the ways that you can go about that is to contact the health plan contact themselves. It really is the first step in a complaint process anyway, and can be beneficial, can be helpful. Using parity like this one, the Kennedy Forum, can be really helpful for resources and figuring out a little bit more information and getting the right forms. I don't know if you guys have ever gone looking for some of these forms and how to contact those insurance companies and file those complaints or appeals, but it can be really hard to find the correct form and to find the correct contact information. So this can be really helpful. APA actually has some letters for us if that's what we're after, specific to the insurance panel, right? So if somebody's insurance plan is a plan purchased by their employer or by the individual, there's a template they can download to help them and how to submit that. If their insurance is through the employer pays for them, is a self-funded plan, then there's one, a template that folks can use. So these tools are really, really helpful. There's a lot of information on here, posters, things like that you can post if you run a mental health office or something like that you can put up to help inform people of what their rights are. And last but not least would be the U.S. Department of Labor and the Security Administration. They have a process for submitting these complaints if and when folks run into barriers, either working with the insurance company themselves and or through Parity, the Kennedy Forum. So there, I wanted to make sure to give you guys some resources to be able to take home, so you can kind of help figure out what next steps are, either for you as a member yourself or as an advocate, mental health advocate. So, Mary, are there any additional questions?
I got a question about getting a follow-up email with all these resources shared. Absolutely. I'm going to send you an email with links from the webinar, and I'll also have a link to the slides where you can look at the slides and click on the links in the slides.
That's
And
great.
a link to the survey, which we'd really like you to fill out also.
That's wonderful. Thanks for sending that out. And I think the most important thing, I think, takeaway to realize is that, you know, not every determination, keep this in mind, not every determination is going to be a parity violation. And so because of that, I think probably one of the most powerful changes that the final rule has given us is the power for each member to request the comparative analysis at any time, because that gives them the ability to take a look at whatever denial that they've gotten, that they've received, and then to look at the comparative analysis. Geez, that word's hard. Comparative analysis, and then to try to make a determination of whether it still looks like a parity violation. Are those services being limited in the same way under medical surgical? And a lot of that is going to be answered in that comparative analysis. And then once you know, we take a look at that, and if people still suspect that, then you can follow through with some of those complaints. What other questions? Anything?
It doesn't look like we have any other
Great.
questions.
Great. We have a whole network of experts now, huh? I'm
Well,
happy to answer questions if people have them later on. Mary, if folks want to email or anything, I'm happy to answer what I can answer, if I can answer. But I think if you're going to send a lot of these links out, I think that's going to be really helpful.
and if anyone has a question right now, put it in the chat, and I'll do some closing remarks and take a look at the chat while we still have Kim here.
Right.
Thank you so much, Kim. Let me take off the spotlights here so that I can, hold on just a second.
Sure. That's all right.
There we go. Anyway, thank you so much, Kim. Wow, that was a lot to digest. And
It
I
really
was
is.
familiar with the presentation prior to it starting.
Yeah.
So as I mentioned, in the next hour, I'll send out that email with all the links in it. And we'd sure love you to fill out our survey. Like I said, it helps us with our funding. And Eden, if you'd put our email back in there again, the Empower Idaho email, if you have any questions, or if you have questions for Kim, I can pass them on to her. There's the empoweridaho@janus.org email in the chat. And the slides and the recording will be available on the website in a couple of days. Thank you, everyone, for attending. Thank you, Lavona, for your ASL interpreting. And thank you so much for all your insights, Kim. It was a great presentation.
Of course. Happy to do it. Thanks, everybody.
Have a great day, everyone. Thanks.
Bye-bye.
Bye.